Hello, and welcome to Overreactive. I'm Dr. Rebecca Dunsmoor-Su.
And I'm Dr. Amy Voedisch, and we are your expert guides on the strange and often uncomfortable journey that is perimenopause.
Hi, everybody, and welcome back. This is Dr. Rebecca Dunsmoor-Su.
And I'm Dr. Amy Voedisch, and welcome back to Overreactive.
We're going to continue our series on the Women's Health Initiative, or the WHI. Let's remind ourselves, Amy, what did we do last time?
I think you and I totally geeked out when that happened, which, shocking.
I know.
Yeah, so I think we got really excited talking about some data, as we do. And we talked a little bit about kind of the WHI study and why it was there and what it was trying to answer. So as a recap for those tuning in today, the WHI, or the Women's Health Initiative study, was trying to answer the question of whether or not hormone replacement therapy could be used to prevent chronic diseases, mainly bone fractures and cardiovascular disease. Those were kind of the two big things.
Right. And as we discussed last time, that's because in previous studies, which were observational studies, so, hey, these women are taking hormones, let's see what happens. It looked like hormone therapy might be preventative for some of these things. And so they really wanted to design a trial that took all the other factors out and randomized people into two groups, either taking hormones or not. And nobody knew who was getting what, so they could really dig down and prove or disprove if these were beneficial, right?
Makes sense. It was actually a pretty interesting study. And there was a lot out there about how the WHI study was a bad study, or it was terribly designed, or it was this, or it was that. And I have to say, there's probably been times in my career where I've been like, oh, just it's the bane of my existence, like trying to dispel kind of what the media did with that study. But actually, it wasn't really a bad study. It was.
No, we continue to use the data to this day.
Yeah. And the data has limitations, but every research study, regardless of how beautifully and perfectly designed it is going to have limitations to what it can tell us about the real world, because it's in a vacuum.
One of the things that gets brought up a lot as one of the reasons it's a bad study is that they enrolled women across the lifespan of menopause. So they enrolled 60-year-olds, 70-year-olds, and they started them on hormones. But we have to remember that at the time they designed the study, we didn't have information that when you started was important.
Right.
Nobody had looked at that. All our previous data was pretty much observational. So you were seeing women who started at the time of menopause because that's when you start them for symptoms.
Right.
But there was no reason to suspect that starting in your 70s would be a problem. So, it made sense to start some women in their 70s because they wanted to look at bone fractures and cardiovascular disease. And those don't happen to women in their 50s. So they could have started a bunch of women in their 50s and had to watch them for 20 years.
Right.
Or we can enroll a bunch of people who are 60, 70, and even up to like 80 years old, and maybe they'll get to those outcomes faster.
Right. So it's a way to be a little bit more efficient. You only have this was a very expensive study.
Oh, very expensive.
What, $750 million or something crazy?
Something crazy like that.
We'll never get that kind of funding again.
No.
And so they wanted to be as efficient with that as they could. So they wanted to enroll people who were going to conceivably develop these diseases in the time frame of the study. So that's why you enroll older people. Remember that these were people who had never been on hormone replacement therapy before. So these were brand new starts, which is very different than when you're in your 70s and 80s and 90s. Not that there's that many 90s-year-olds on hormone replacement therapy, just by numbers. More and more. So these are people who hadn't been on them before. And so that's a very different patient population, or a very different population of people. But we didn't know that. We didn't know that it made a difference when you started it at the time of the study. So I think they designed this study as well as they could with the information that they had at the time.
Absolutely.
And my issue has never been with really the design of the study. I mean, in retrospect, you can Monday morning quarterback it and be like, they should have enrolled younger people to more represent the real world, but that wasn't what they were looking at. My issue has always been the way they rolled out the studies, and that includes the authors. They're responsible for that, the way they rolled out the information and how it was given to the media and how it was given to the lay public. But we'll get into that in a second.
Just as a little background, it wasn't just a study of hormones and cardiovascular disease and bone disease. There were actually multiple arms to this study. They wanted to look at a lot of things. If they were going to recruit this many people, they were going to find out everything they could. So we've been getting publications from this study for 20, 30 years
Yeah.
now.
Continuing to still get some.
Yeah. And so there were arms that looked at dietary intervention to see if it made a difference in breast and colorectal cancer and bone fractures. There were
Yep.
studies of vitamin D and calcium that were in there too. So we only ever hear about the hormone side, but this study
Right.
looked at so many things that impact the lives of women and their chronic diseases as they age. And I think that's really important. It's so rare we get such a comprehensive study funded.
Right. And for women.
Yeah, and for women.
I mean, never going to happen in this lifetime, people.
Yeah.
So
And one of the interesting things from a study design perspective is that the women who didn't qualify to enroll in any of those arms were put into an observational study. And we'll just
I know.
watch them.
which was kind of cool. So either they couldn't be enrolled or they didn't want to be in potentially the placebo group. So these are people who wanted to be on hormone replacement therapy, didn't want to be in the placebo group. And so they were in this observational study, which had like, I don't know, 93,000 people or something. It was
Huge number. Yeah, huge
Huge
number.
number. And then they could watch them. So this observational study has also been given us amazing information as well. So, again, it's gotten some bad rap, it's gotten some bad press, and for some of it is legit, and it should. But I myself have had to sort of like tone down my dramatic outrage.
Yeah, well, I think that's also just aging on both of our parts. We've had to deal with this data now for 20 years. We've come to terms with it.
We have. I'm like, oh, look, another WHI study. How exciting for us.
Do you want to take a couple of minutes and sort of describe the two groups who are on hormone therapy or theoretically on hormone therapy, but possibly on placebo?
So we had two groups. There were two arms. And within each arm, you were divided up into either receiving hormone therapy or receiving a placebo, meaning you think you don't know what you're getting. So nobody knows what you're getting, but you're getting something. So either the placebo or the hormone. If you had a uterus, you were in the estrogen and progestogen group, and that was given to you in conjugated equine estrogen and medroxyprogesterone acetate. So you're either in that group, or if you didn't have a uterus, then you're in the estrogen only group. Because remember, we've said many, many times that if you have a uterus and you take estrogen, you must be on a progestogen or progestogen type medication to counterbalance the effects of estrogen in the uterus. So those are our two groups. In the estrogen only arm, we had about 10,000. And in the estrogen progestogen group, we had about 16,000 people. And then those were divided up again, and half were randomized to receive the placebo and half were randomized to receive the medication.
It's important to recenter on what were they actually looking at. So their primary outcomes were cardiovascular and hip fractures. Breast cancer was not a primary outcome. Breast cancer was a safety outcome. They were looking at breast cancer not because they hypothesized changes, but that was something that everybody was worried about. And so that was one of the safety things that they analyzed at different time points. So it was not designed to assess for breast cancer.
Right. And it's different sort of when you're calculating out the numbers, when you're trying to look at an outcome and a difference between groups versus the safety group. Those are, I'm not going to get into the nerdy details on that, but it's slightly different.
So many times, Amy.
I know. I'm holding back now.
Okay, good.
Look at the restraint. So the study wasn't designed to really look at breast cancer, was not an outcome that they were looking at per se.
Mm-hmm.
Okay, so do tell, what were the results?
I think first we should talk how we're going to describe the results, because one of the things we've learned in the subsequent years, when they first published the results, they published them as a group of women, the whole group. And the problem with that is that group spanned 25, 30 years, right? And those women have age range.
Yep.
They have very different risks. So as we're describing the results, we're taking into account sort of several different sources of information. There's the original publication, which had everybody grouped together. There's later publications because they were able to divide them out by age ranges. So they did the 50 to 59, 60 to 69, and 70 to 79 groups. And so we'll take some of that data because the results were different among different age ranges, as one can imagine.
Right.
And then we're also going to bring in some of the data we now have of the 20-year follow-up. So they have continued to follow these women, even though they're not getting an intervention anymore. And that's really important for long-term risk.
And one of the things to sort of think about with this study is that they did stop it sort of prematurely. So, which is kind of unfortunate. So, some of this data we have that's they've been following these people for 20 years, it's based on that short period of time that they took hormone replacement therapy
Right.
for the study. A little bit different, but yeah, it's been really interesting. And when we look at it, I mean, you and I could sit here and talk about what the data showed in 2002, but that's not actually helpful to our listeners. We
No.
want to talk about like what do we know now after 20 years and putting the whole story together? Because if you
Right.
just go by the 2002 story, it's like, the root of all evil and no one should be on it. And it's the worst thing that's ever happened to women.
Correct. You just mentioned this. They stopped the study early. So first they stopped the estrogen and progestin arm. And the reason they stopped it, as everybody knows, was that they said that it was a safety stop because they were seeing more breast cancer in the women on estrogen plus progestogen than they were in the control or placebo women.
Mm-hmm.
Let's take a moment to center on that. Even in the initial report, which has since been altered to take into account confounding factors, and the statistical significance is no longer there when you do that. But even if you take the very first report, it accounted for about 1.2 additional cases of breast cancer in 1,000 woman years over the placebo group for that arm. And I say that very specifically because the placebo group for that arm had a much lower than the average rate of breast cancer.
Mm-hmm.
So that particular placebo group, for whatever reason, was at lower risk for breast cancer than the general population. So they had to compare those two groups because that's how the study was designed. But if you actually compare it to like the general going rate, it doesn't come up to significance. And once they took into account some of the reasons they had such a low rate, it didn't come up to significance. But this was their safety stop point. They met that stop point. They had to stop. That's how we design studies. They had to do it. And then the estrogen only arm continued for a while.
Mm-hmm.
And eventually they started to see signal that maybe it was increasing stroke risk. So that eventually stopped as well.
Right. I think it ran for about 7 years,
6 or 7 years.
6 or 7, something like that. Mm-hmm.
Yeah. But anyway, we still got a lot of data out of this because a lot of women were in this study.
Yeah.
So I thought maybe it'd be helpful if we go through it sort of by all the different chronic diseases that we can talk about based on this data.
Yeah.
So Amy, you want to start with bone health?
Sure. We'll start with bone health because that was one of their big things that they wanted to look at. And we'll definitely talk about cardiovascular disease because that was the other big one for shizzle. So we'll definitely talk about that. So when we look at bone health, remember you talked about how you can put all the data together and then you can divide it out by age. So if you put all the data together, they did see a reduction in fractures in both of the groups, which isn't really surprising. If you think about estrogen, the way estrogen works in the bones, it's a bone builder. It helps to increase bone density. So, I think that that's actually not super surprising. I also really think it's great that they looked at fractures because we use bone mineral density as a surrogate marker for fractures. But really what we care about is your fracture risk because it's the fracture that's, what causes the morbidity and the mortality for people.
Right.
And so we really care about fracture reduction. So I thought that was really great.
They did note the bone mineral density also increased, but I was really pleased that they looked at fractures. And remember, one of these arms only ran for 2 years and they were still able to detect reduced fractures in the whole group.
I think we can say that hormones are really helpful from a bone perspective. I mean, we kind of already knew that, but it's nice to sort of have that information.
Right.
More helpful in the sort of post-menopausal, like the older age range is where we saw that reduction in fractures. Like when we divided it out by age, the younger folks didn't really see much of a reduction in fractures, but it might be because you're younger and you don't really have a lot of fractures in your 50s. But when you're 60, 70, and 80, you're much more likely to have a fracture. So it may not have necessarily been that the estrogen and progestogens or the hormones weren't being helpful. It's just that the incidence was so low in those particular groups that it was difficult to sort of ascertain that information.
Really important point that they make based on the study is that, you said that they didn't reduce fractures in the less than 60-year-olds. But, sometimes we think, well, if we use it when you're 50 to 59, maybe it'll prevent fractures when you're 70. Turns out when they stopped the medication, they had a rapid loss of bone mineral density to pretreatment levels. So to protect your bones, you have to stay on it.
Yeah.
You can't take it for 5 years when you're 50 and have the benefit when you're 80.
Right. Doesn't work that way. It works when you're on it, but it doesn't work when you're off it. You can't bank bone mineral density for later. It's not worse. The fracture risk is
You can when you're 20.
yeah.
It's a little different physiology.
little different. But when with hormone replacement therapy, we're not able to
Right.
save up for later for a rainy day type of thing. And it didn't make fracture risk worse, like being on it and then going off, which is
Right.
a good question. And it didn't make your bone mineral density worse than it would have been at baseline. So it doesn't hurt you, but it really helps you during the time that you're on it.
Correct.
Which is one of the reasons why now, for me in my practice, I don't routinely recommend that people go off
Right.
unless they have another particular
A reason.
but because I'm like, there are some real benefits of staying on it, especially from a bone health perspective.
Yeah. So one of the other things they were able to look at was what we now call metabolic disease. But one of the things we know about perimenopause and then into the early menopause is that we see a change in how we process sugar and insulin in our bodies. And especially women who are at higher risk of type 2 diabetes, whether it's because they've been PCOS, polycystic ovarian syndrome all their lives, or they're pre-diabetic already, or they have a strong family history, they have a huge risk of developing type 2 diabetes, especially through that perimenopausal into menopause transition.
Right.
And so they looked at, was there a difference in the levels of developing type 2 diabetes in women on versus not on hormones? And in both groups, they showed approximately a 19% reduction in type 2 diabetes, which equates out to about 16 fewer cases per 10,000 woman years. Other studies have confirmed this in a very similar way, and the estimates are anywhere between 18 to 30% reduction in diabetes. The 30% is more for those very high-risk patients, but in all comers, this reduces your chance of developing diabetes while you're taking it. And that's important. That's a long-term health risk.
Yep. That's a long-term chronic disease. Now, this study wasn't looking at type 2 diabetes. They just happened to be kind of monitoring that. But I think that's really important because I have so many people who come into my office and they're like, I don't know what to tell you, but I don't have diabetes yet, but I'm starting to get pre-diabetic and my sugars are going up. And then this kind of leads into other cardiovascular things. Because when we think about diabetes and metabolic syndrome, it's all part of like a whole picture of our cardiovascular health and where are we putting ourselves at an increased risk of having coronary heart disease, heart attacks, that type of thing.
Correct.
So that was a big thing that they wanted to look at was, cardiovascular disease. So what did they find, Dr. Dunsmoor-Su?
Well,
Do tell.
yes. So cardiovascular disease is one of those things you really need to look at split among different groups.
Mm-hmm. Oh, yeah.
So when they first reported, they reported the whole cohort together. And what they said was that they had an increased risk overall. But if you drill down to those women who were 50 to 59 at the instigation of the study or the beginning of the study, they actually had a reduced risk of coronary heart disease, a reduced risk of heart attack. And then the stroke risk was kind of mixed. It was a little weird. There were some weird signals in the data. And so there was some increase, some decrease, and it didn't make physiologic sense.
No, it made no sense. So I'm not sure we could answer. The
Right.
study wasn't powered to really look at stroke risk.
Especially not in that younger group.
No.
Where it's very rare. In the older groups, there was some increase, and that was concerning. And that's actually one of the big takeaways that we actually take away from this study, which is one of the main reasons we do not recommend starting hormones when you're 10 or more years into your menopause. So 60, 65, 70 is because we are going to increase your cardiovascular risk, your risk of coronary heart disease, your risk of stroke, your risk of heart attack. And that has a lot of downstream effects. And, heart disease is the number one killer of women.
Right.
This is important. Heart disease is what we should all be thinking about. And we don't want to do anything that's going to increase that risk. You probably see this every week or every couple of weeks. I get a woman into my clinic who's 68 and says, I just heard that hormones are good for you. I want them now.
Every day.
And I have to break the bad news that that would have been true 15 years ago,
Yeah.
but it's just too late. And it's, you know, as I say to all my patients, you know, it's not your fault and it's not fair, but it is what it is. I will hurt you more
Yeah.
than I will help you at this point.
And it's really hard. There's sort of this lost generation. It's the people who would have 20 years ago been in their late 40s
Right.
and are now in their late 60s who have really felt the negative impact of what happened in July of 2002 when the WHI study results came out.
Yeah.
And that group, they come in and they're hearing all this news and all the Instagrams and the podcasts.
Right.
And they're saying, I should be on hormones. And it's really disappointing to have to tell them from a cardiovascular standpoint, I really can't do it.
No, I really don't recommend it.
No.
One part of cardiovascular disease I didn't mention, maybe you want to talk about blood clot risk, because that's important, right?
Yeah. So when you're on an estrogen, typically estrogens will increase your risk of blood clots. And the reason why this happens is because estrogen is metabolized by your liver. Your liver is where the factors are made that cause blood clots. That's what your liver does. It's one of its many fabulous jobs. And when estrogen is metabolized by the liver, it leads to an increase in some of these clotting factors, which makes your blood a little more sticky. Now, that increased risk is low, even on something like a birth control pill, where the estrogen level is a lot more potent. But we do see that slight bump with hormone replacement therapy and estrogen therapy, I should say, in particular. And that risk didn't really change based on age. It was just sort of like whether you were on it or not, it was a slightly elevated risk. And it's less than 10 cases per 10,000 women year users. It's a very, very low rate. And we have more data now that says if you take it in a non-oral route, because remember, the WHI or Women's Health Initiative study used oral estrogen. And so now we don't really use oral estrogen as much because we have other options and because we know if you take it in a non-oral form, it decreases your risk of having blood clots in your legs or your lungs. Now, that's, again, the overall risk is low. So if someone's listening who's on oral estrogen, please don't rush to your doctor and say, oh my gosh, I have to get off of this. Because again, the overall risk is very low and there's reasons why oral might be the best choice for you. But in general, we try to mitigate risk as much as we can. So that's a pretty low risk, but it's there kind of regardless of age.
Sorry, everybody who's listening to the podcast. My cat has decided to join us for the remainder of the podcast. So if there's purring into the microphone, I apologize profusely.
It's a very cute cat, so they can join.
Yeah. So one of the other risks that I really want to talk about is dementia, because I think that's been in the news a lot lately.
I get a lot of people coming in saying, I need to be on it. I want it. People with no symptoms, late 40s, early 50s, saying, I need to start hormone replacement therapy because I want to prevent my risk of getting Alzheimer's disease or dementia later in my life.
Right.
So what do you say to those patients when they walk in?
I tell them that unless they have premature ovarian failure, that's not going to work, at least not based on the data we have to date. With what we know now, and a lot of this is based on the Women's Health Initiative, because they did look, and they looked both at people who were on estrogen, people who are on estrogen plus progesterone. They split it out by age groups. So what they found is that none of the age groups had a preventative effect for dementia. Sorry. We have a video going. You can watch us on YouTube, and the cat is the star of the video right now.
Right, definitely.
So in none of the age groups did it prevent dementia. So for the younger age groups, it was not harmful. It did not increase dementia long-term. And this is from a lot of the 20-year follow-up data. But it did not make it any less likely.
Right.
In the older groups, it did make it more likely. So it actually increased dementia rates. And this is all-cause dementia. We're not necessarily talking just about Alzheimer's disease, which is what everybody fears. And one of the things they really couldn't assess was what was the type of dementia, because there's a form of dementia called vascular dementia, where the blood vessels in your brain cause very tiny injuries to your brain and you become demented. And it's possible, given what we know about blood clotting and estrogens and how our blood vessels change as we age. And then if you add a clot on top of a blood vessel, you can have very small strokes. It could have been very much a vascular dementia picture. We can't really say. but that's our best leading theory as to why if you're older and you start estrogen, you may increase your risk of dementia.
So for that 68-year-old who comes in and says, I want to be on it, not only is it a heart health issue, but it's a cognition issue.
It is.
And I want to also point out that this is different, kind of getting back to perimenopause. This is different than perimenopausal brain fog,
Oh, yes.
where you come in and you're like, I can remember nothing. I have no idea why I walked into the pantry. I drove the wrong kid to school yesterday.
Yeah.
Blah, 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 blah. I can't remember anything. I can't keep, everything
Names
going in my brain.
head.
Yep.
Names are my worst.
That's forget it.
Yeah.
I mean, thank God I've known you for as long as I did. I feel as though it's imprinted in there by now, but
Yeah.
it could happen where I'm like, that person that I do the podcast with. So that's different. That's perimenopausal brain fog. That is not dementia. That doesn't put you at an increased risk of dementia. But I have patients who have these symptoms and think, oh, dear Lord, I'm going to get dementia. I need to be on menopausal hormone therapy so that doesn't happen to me.
Right.
The menopausal hormone therapy can be helpful for brain fog symptoms, but brain fog is usually worse in perimenopause and early postmenopause and will get better.
Right.
So
that's a really good point. And another really good point to bring up is that all of the studies we have that speak to dementia and give us this data are studies where women took hormones for 2, 5, 6, 7 years. We do not have an overarching study where women started hormones in their 50s and took them until the age of dementia to tell us if you do that, will it prevent dementia?
Right.
Now, we don't have any evidence that it will, but I can't say for sure that's not the case. And the reason I bring that up is because we do have some studies that show that women who go through menopause very early, so women who go through menopause prematurely, so before the age of 45, that if you immediately start hormones in them and continue it at least through the natural age of menopause, which can be 15, sometimes 20 years, we do impact their dementia risk. We reduce their dementia risk. So the length of use may have something to do with that. Right. I'm not saying everybody should go out and take hormones for 30 years because I hypothesize that it will help with your dementia. We don't have that data. We just don't have it. It's a great study. Someone should do it. And when someone has an extra $800 million, I'm your gal. I'll help you design it.
Totally happy to run that for you. Yeah. No props. Just text me. Totally there for you.
All right. We've already really talked about the breast cancer risk, but one factor we didn't bring up with it is that they have looked at breast cancer long-term in that 20-year follow-up data. And this is really important. So one thing we didn't specify, Amy, you want to talk about the difference between estrogen alone and estrogen plus progesterone? Because I thought that was a really interesting piece of information for the WHI.
Fascinating. I know. So when we saw that increased risk of breast cancer, it was in the group that took estrogen and progestogen together. So the conjugated equine estrogen, the medroxyprogesterone acetate. Nailed it when I said it, by the way.
Yeah, I saw that.
So that group together, we did see that increased risk of breast cancer. And that was kind of across the ages. Like, again, that wasn't based on if you took it earlier or later. That was just an elevated risk. The absolute increased risk was low. So it was about 9 additional cases for every 10,000 women year users. So that's very low. So less than, you kind of extrapolated out a little bit. The Menopause Society sort of extrapolated that to say it's like less than 1 case for every 1,000 women users annually was sort of the way that they presented it. So that's a pretty low absolute risk. It's not zero. It's not nothing. But if we put it in sort of context, it's slightly higher than drinking 1 glass of wine a night, but less than drinking 2 glasses of wine a night, and less than being overweight or obese.
And don't forget red meat. If you eat red meat, you're increasing your risk even more in the U.S.
Basically speaking, between the wine, the weight, and the red meat, I'm pretty much...
Yeah, you're screwed.
Yep, I'm screwed. Okay, good. Well, might as well just keep drinking and eating red meat then.
There you go.
So that was the slight increased risk. Now, there was no difference in mortality.
Not even at 20 years. Those women had no difference in mortality from breast cancer.
Yes. It didn't mean you were more likely to pass away from breast cancer. It just meant you were more likely to be diagnosed with breast cancer, but just as likely to die from
cardiovascular disease.
Cardiovascular is probably more likely what was happening. Cardiovascular disease. So that's kind of exciting. When you look at the estrogen-only group, it's a different story. Not only did it not increase your risk of getting breast cancer, no, it didn't, but it decreased your risk of getting breast cancer. So there was actually a reduction in the incidence of breast cancer cases in women who took estrogen only.
And we've seen this in other studies.
Mhm.
It keeps popping up.
So there's something about the estrogen progestogen together or the progestogen component that increases your risk of developing breast cancer. I think that's a really interesting distinction for patients. Now, most people need to be on both an estrogen and a progestogen because they have a uterus, but it really does inform sort of some of my counseling points, what we talk about, the different options that might be on the table. How do we mitigate that risk? So there's other conversations to be had with that, but I think it's an interesting distinction because oftentimes they'll come in and be like, I can't even be on vaginal estrogen. I could increase my risk of breast cancer. And I'm like, oh, there's so much to unpack with that statement.
Yeah, exactly.
So,
And importantly, it also reduced their mortality from breast cancer long term.
yes.
When we followed them up 20 years later.
I mean, really interesting. So the reduction in the incidence and the reduction in the mortality. So just in the estrogen only group. So estrogen is not the root of all evil when it comes to
No.
breast cancer. I'm not saying you should go on estrogen for the primary prevention of breast cancer. That's
No.
a totally different
The
conversation.
reduction wasn't that big.
No, it's not that big. But it's something that I think, especially in what folks who are only on the estrogen, it can be reassuring to them to hear that data.
Absolutely. Yeah.
And so much of the WHI study focused on breast cancer, but there were other cancers that they looked at. Do you want to talk about those?
Yes. So they looked at 2 additional cancers. They looked at endometrial cancer, and we've talked about this before with the IUD studies. And endometrial cancer, the prevention is positively impacted by progestogens. So not surprisingly, the women on estrogen only didn't have a uterus, so they didn't look at them. But the women who were on estrogen plus progestogen had a reduced risk of endometrial cancer or uterine lining cancer over the women taking the placebo. Because it does develop even if you're not taking estrogens as we age.
It can happen for a variety of different reasons.
Right.
Yeah.
The other thing they noticed was that with colorectal cancer, for the length of time that you were on the hormones, you had a reduced risk of colorectal cancer. So that's another one, sort of like the bone health, where you sort of lose it once you come off of it. It's not a huge reduction in risk. Other studies have told us it's about a 10% reduction in risk. But
yeah,
we're seeing more and more colorectal cancer. And it's something that with excellent screening and preventative measures, hopefully we can impact.
Yeah.
And then last but not least, they looked at all-cause mortality, didn't they, Amy?
We didn't talk about all-cause mortality.
I love all-cause mortality
It's one of my favorite stats.
That's really what people want to know, right?
I
Am I
know.
going to die?
Is this going to make me live longer?
Mm-hmm.
Like, am I going to die sooner? Am I going to die later? Am I going to live longer? What's the scoop? It's one of my favorite stats of the whole thing. So all-cause mortality basically just looks at deaths for any reason.
Yeah.
And
car crash to cancer to heart disease.
Any cause of death. And they looked at it in each of the hormone arms and each of the placebo arms. And so, dun, 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 what did they find?
Well, in the younger hormone users, both arms, whether it was estrogen alone or estrogen plus progesterone, they had reduced all-cause mortality at the follow-up. So they were alive in greater numbers than those who had been given placebo.
That's very exciting.
And very important. I mean, it was not hugely different because these women were still relatively young at the 20-year follow-up, but it was different.
And that's actually, I mean, something to kind of think about. And there may be, confounding reasons or whatnot for why that's the case. But overall, when I think about the risk-benefit profile, when I'm counseling patients and trying to help them decide what's going to be best for them, in general, I'll say, if you're a young, healthy person around the time of your final menstrual period, whether it's perimenopause, early postmenopause, ideally within 5 years, but definitely within 10 years of that last menstrual period, the benefits usually outweigh the risks for people. Not only does it help you with all of the symptoms, but you see this reduction in all-cause mortality. You see a reduction in colorectal cancer. You see a reduction in bone fractures. You see a reduction in endometrial cancer. So there's a reduction in type 2 diabetes. I mean, there's a lot of benefits, medical benefits for being on it, not just quality of life, but a lot of medical benefits.
And a lot of those benefits have been shown in other studies, not just the WHI. So we
Right.
want to make clear we're only analyzing the WHI at this podcast, but we see these signals pop up over and over again to tell us these things.
Because not only in the last 20 years do we have more data that has come out from the WHI study, they've published more and more studies as they followed patients out farther, but we have other studies have been done. There's been other long observational studies. There's been other randomized controlled trials. So there's been other data that is added to sort of this whole overall picture and really fleshed it out. And so, and almost all of them are, kind of conclusive that it really matters when you start the hormones. And that's why it breaks my heart when I have the 68-year-old who I'm like, sorry,
too late.
It sucks, right?
Yeah. And we just gave you a ton of data.
Yeah, it was a lot.
But I'm going to sum up. What the WHI tells us is that breast cancer is only part of the story. As Amy just said, risks may outweigh benefits. Benefits may outweigh risks. All of this needs to be balanced for you in your particular life, your family history, your personal medical history, your personal risks, and what we're trying to treat. It's an individualized decision. And seeing a menopause expert who has all of this data to help you to make that individualized decision is the best thing you can do if you can access one.
Right. And the way to do that, you can find someone in the Menopause Society. They have a database. You can check out folks there. Certainly, if you're in the state of California, I can see you. Dr. Dunsmoor-Su works for Gennev, which is a large national, very evidence-based, which I just love, telehealth company. And they have providers and doctors in every state.
Physicians who see patients in every state. So certainly seek us out. We do take some insurance. So you may have an insurance that we take.
I know you do not toot your own horn, and so I'm going to do it for you. They're one of the only telehealth companies that has physicians in every state. So a lot of telehealth companies will have you see an advanced practitioner, like a nurse practitioner or a physician assistant, which is totally fine. They're not to take away from AP, like we call them APPs, not to take away from them at all, but it's a very different level of training. And so it is not the same. Right. And so it is really nice, especially when you're in something that's complex or you might have a complex history of being able to see a physician, I think is really nice. And because we're having sort of a decrease and we're having an OBGYN shortage nationwide, especially in rural counties, it's really nice to be able to have something like this where you can access care. So I don't work for Gennev. I don't get any money from Gennev. I get no financial kickbacks. I have no financial disclosures. But I just wanted to sort of point out how awesome I think that is.
Oh, thank you. I appreciate it. So one of the other big points that we've made tonight is that when you start hormones makes a difference. The Menopause Society, the Global Menopause Society, the International Menopause Society, they all recommend ideally starting within 5 years of your last period, but the sooner the better. And that's why a lot of women now come see us in perimenopause to talk about when is the ideal time to start.
I prefer to see you in perimenopause. Please come early.
Right. And if you're in that sort of 5 to 10 year range, you're probably risk neutral, we like to say. You're not getting some of the benefits. You're maybe not seeing some of the biggest cardiovascular risks yet, but it's more of a conversation. We might do more evaluation of you during that time. I often do a cardiovascular workup before we start hormones during that time in case you're someone who maybe has a higher risk. And another point to make is that we often hear, because when the WHI released in 2002 and we didn't know what to do and there's women who were still insisting on taking hormones, the societies came up with a recommendation, which was take the lowest dose for the least amount of time.
Right.
That is based on nothing. There is no data that tells us that that is the strategy we should be using. It's actually still written into the current 2022 menopausal hormone therapy position statement. It is not based on data. And some of the data tells us that actually longer use may have some benefit. And there's a interesting study that looked at Medicare users who were still on hormones that came out last year. So maybe we'll pull that one in someday.
Oh, funsies.
But we don't know that that's the case. So I tell my patients, I'm going to use as much as is needed to make you feel good, not the lowest dose. The lowest dose of hormone therapy that we use now, the little tiny little patch, That's what I use in my 80-year-olds. That stuff is not enough to solve the perimenopausal mood swings
No.
and hot flashes and all that stuff.
And you probably need a lot higher doses in
Yeah.
perimenopause than you're going to. And as you get older, you will need less. But for now, yeah, we're not using massive doses, but we're
No.
using a dose that's going to work and be beneficial.
Yeah, all of the patches that we have. So most of us start with a patch, either an estradiol patch, and all of those patches are very small doses and very low potency. Like not even the biggest patch is not actually that much estrogen.
Right. Yeah, exactly.
Yeah. And I don't tell my patients they have to stop by a certain age or after X number of years of use.
No.
We reassess every year. We say, hey, have you had any changes in your health history? Have you gotten your mammogram? Are all these things okay? And does it make sense to continue for you? And some women choose to come off and some don't. And that's how we counsel.
And so the reasons why you would go off hormone therapy, this is generally what I tell patients, is really if it's number one, if you want to, anytime you want to go off, you can totally go off. And then the other sort of like medical catastrophic reasons why you need to go off hormone therapy are you personally develop cancer, breast cancer.
Right.
Not your mom, not your sister, not your aunt, not your cousin, not your best friend. But you develop breast cancer. Then we want to stop hormone therapy. You have a heart attack. You have a stroke. You develop a blood clot in your legs or your lungs. Those are the like reasons why we really think about, or you develop dementia. You know, and then we're saying, okay, there's something going on here and you need to be off hormone replacement therapy.
Right. Exactly.
Or menopausal hormone
it's
therapy.
It's about your personal risks.
Yeah.
And there was one other point I wanted to make, and I forgot to make it while we were talking about breast cancer with the WHI. And it's, I think, an important point to think about, which is they stopped the WHI E+P group for increased breast cancers at 2 years.
Right.
Breast cancer doesn't develop in 2 years.
It doesn't? No, it does not.
And estimates in the oncology literature say it takes anywhere from 6 to 9 years to develop a breast cancer from the beginnings of abnormal cells.
Okay. Yeah.
So probably what we were doing with this study was unmasking something that was already there.
Right.
Whether it's because we were screening more regularly because mammograms were part of the study, or whether it was because maybe in the population in this age range, people just have precancers that are sort of scattered in their breasts. And if you have a precancer, hormones may bring it to the surface faster. It was still going to show up at some point. We just brought it out faster. So I do tell patients, when we start hormones, you might develop breast cancer. 1 in 8 women get breast cancer. So you might be one of those women. Doesn't mean you caused it by taking hormones.
Right. Yeah.
It means you took hormones and you have breast cancer.
That's kind of all we can put together with it.
Amy, round us out. Bring it back to perimenopause. Why are we talking about this for a perimenopausal?
It's all about perimenopause. And so what I'm so happy is for those who are in perimenopause, you're not in that lost generation of people where it's too late to start it. You have the chance to intervene now to hopefully make a difference for you and your symptoms and what your journey in your life looks like. Neither one of us thinks that every single person should be on hormone replacement therapy or menopausal hormone therapy, as we're calling it now, MHT. We don't. Like, it's not for everybody. But if you're having symptoms or there's things that are going on in your life where you feel like, hey, maybe the benefits of this outweigh these small risks that are there, then it's time to find your physician and have that conversation with them.
Right. It's a great time to plan.
Yes, this is about planning and intervention because early intervention is key. For those of you out there who have kids with learning disabilities, the earlier you intervene, the better of an outcome you're going to have. And it's kind of the same thing here. Like we want you to be armed with the information so that you don't go to your doctor in 20 years and say, I really wish I'd started hormone therapy. Like we want you to know that this is an option for you. Here's your window of when to start it. It's okay if you don't want to. I don't walk around putting random patches on people because I think everybody should get it.
I think people sometimes think we actually do that.
I know. Like I don't give it. It's like it's not in the trunk of my car. I'm not just like randomly like putting like secret like patches and chips underneath people's skin. So, but I do want people to know that it's an option and it's out there. So the whole point of this episode, and I know it's like very nerdy and we're getting into all these nitty gritty details, is because it's just so important for you to understand what the data actually showed us and how that pertains to you and what we know now so that you can get away from any fear mongering because you will probably encounter physicians, nurse practitioners, physician's assistants who'll say to you, you can't be on hormone replacement therapy. Or if you're on it, oh, you need to get off of that. Like that's not, there's new data out there. There's a new understanding. And
it takes a long time to re-educate everybody.
yeah, it takes
It really
very
does.
long time. It's taken me a long, like I didn't just know this. I had to teach myself and it took me a long time. I had to do a lot of reading. I went to a lot of conferences and it takes a long time to sort of reset that mindset. So I'm not begging on your, on your doctors or your nurse practitioners or anybody who says that. They don't know and it's not their fault. And so it's just advocate for yourself and find somebody who really understands the literature and what's out there to be able to counsel you.
Yeah, I think it's a really good point. There are excellent primary care doctors who don't understand menopausal hormone therapy. Just like I think you and I are pretty darn good gynecologists who you probably wouldn't want treating your diabetes.
I'm really not very good at that.
No.
I'm not sure how that would go for you.
I haven't learned it and I don't know it. And the last time I studied diabetes was 22 years ago in med school.
I was going to say, if you want a therapy from 20 years ago, I am happy to give that to you.
I know how to use insulin.
Great. So there we go.
But anyway, so
we digress.
It doesn't make them bad doctors.
No.
It means that is not their area of expertise. And that's okay.
Yep.
We cannot all be expert in everything.
No, exactly. We can't. And so thank goodness that they're there doing their job and we're doing our job. And so
I couldn't do their job.
No. Thank you.
That is the hardest job in the medical community.
For sure. Godspeed to all the primary care doctors out there. We love you and thank you for doing your job. And please don't quit.
Please don't quit because we can't do it.
We can't do it. Gynecologists, we're just not equipped for that.
No.
That's a whole lot of crazy. So this is I think the end of our episode. I think we've we've hit all the high points and I feel like our listeners now are armed with the real data and the information that they need to pick the best journey and pathway for themselves.
And remember, you're not crazy. This is really happening.